Hi, my name is Dr. Ellen Mowry. I'm a professor of neurology and epidemiology at the Johns Hopkins University in Baltimore, Maryland, in the United States. And today I'm going to give you an update on diet and multiple sclerosis. Here are my disclosures. So, in conceptualizing the relationship of diet and multiple sclerosis, we really think about diet, obesity, and related disorders in a complex way because we think that they're all intimately related to one another and may impact either individually or synergistically on the risk or course of multiple sclerosis. So, for example, diet may be related directly to obesity and related disorders, and thus have an impact on the risk or course of multiple sclerosis. It might also do so through the gut microbiota and changes therein, which can both relate to obesity and related disorders, but may also impact directly MS-related phenomena. And it's possible that diet has a direct impact on MS risk or its course without influencing or in addition to having an impact through these other mechanisms or mediated by these other mechanisms. We're going to focus mostly on the first and last mechanisms today due to interest of time. So first, we'll discuss some of the evidence supporting a potential role for obesity and related disorders in the risk or course of MS. Next, we'll discuss the current epidemiologic literature surrounding diet and MS risk or prognosis, and then we'll talk a little bit about some of the challenges of conducting trials and the results thereof. So first, how might obesity be related to multiple sclerosis? Well, in general, obesity promotes leukocytosis in adipose tissue, and this can lead to a chronic inflammatory state. This chronic inflammatory state may promote type 2 diabetes and cardiovascular disease, and may also directly be related to neurodegeneration. Obesity also is associated with increased lipogenesis in primary lymphoid organs, such as the thymus or bone marrow. And this may alter immune surveillance and is hypothesized to promote autoimmunity, infections, and potentially cancer. And these findings and thoughts are quite concerning, of course, since we know that obesity and overweight individuals are increasingly prevalent throughout the world. The United States is sort of leading the charge, but really throughout the world, we see trends where greater and greater percentages of the population are overweight or obese. What about obesity and its relationship with MS risk? Well, one of the most interesting studies, I think, came from the Kaiser Permanente Southern California cohort, in that they were able to measure directly from medical records that evaluated weight and height prior to the onset of multiple sclerosis, whether that preceding weight and height was associated with MS risk. And this is looking at a group of pediatric onset MS patients. And they saw in particular that for girls, those who were extremely obese compared to the reference population of under or normal weight individuals were nearly fourfold more likely to develop MS over the intervening period of time. Such a relationship was not demonstrated in boys of interest, and it's notable that the sample sizes were too small. The Nurses' Health Study had asked healthy nurses at the time whether they had had various types of bodies throughout their life and had demonstrated an association, particularly in late adolescence, of larger body habitus with subsequent MS risk as well. That, again, included women. But in Sweden, an association between obesity and MS risk was also demonstrated in males. Interestingly, several Mendelian randomization studies have evaluated genetic variants associated with higher BMI and indicated that those genetic variants indicating higher BMI risk were in fact associated with greater risk of multiple sclerosis over time. And the references for those are indicated on the right-hand side of the slide. What about obesity and related conditions and their association with the course of multiple sclerosis? Well, there are several cross sectional studies that have demonstrated an association between obesity, as measured by body mass index, and MRI activity. Uh, Other studies have looked at lipid profiles and shown that those with low HDL, higher LDL, and higher triglycerides have a greater tendency for new T2 and contrast enhancing lesions and greater lesion volume overall over time. There was a small pilot trial looking at intervening with oral diabetes therapies, and that demonstrated that those treated with metformin and pioglitazone, as demonstrated on the graph on the right, were less likely to have new gadolinium enhancing lesions, as well as fewer T2 lesions. Another longitudinal study looking at patients with MS who also had migraine, elevated lipids, or at least three important or impactful comorbidities, and they were shown to have a greater relapse rate. In our own cross sectional analysis of the 10 site MS Paths study, which collects neuroperformance and imaging data on patients in the real world, over time. We first looked at their cross sectional data and the relationship between the number of obesity related comorbidities, namely diabetes, high blood pressure, or high cholesterol, with neurologic performance in the clinic. And we saw that those with two or more of these comorbidities had slower walking speed and impaired manual dexterity and processing speed relative to those without obesity related comorbidities. That included nearly 12,000 individuals of more than 6,000 people who had standardized brain imaging to share. Those with two or more of these same comorbidities were also overall likely to have lower brain parenchymal fraction. And in particular, when we look at volume subsets, gray matter fraction and cortical gray and deep gray seem to drive that, with those with two or more of the obesity related comorbidities having lower volumes in all of those metrics. Longitudinally, with respect to neurodegeneration, in the UCSF EPIC cohort, we looked at nearly 500 individuals with relapsing remitting MS or clinically isolated syndrome who were followed with systematic imaging for a 5-year period of time. And we saw that those with greater body mass indices were more likely to have accelerated loss of normalized gray matter volume. And then at Johns Hopkins, in a cohort of individuals followed regularly with optical coherence tomography, or OCT, investigating over 500 individuals with MS for over 4 years in follow-up. Those who were obese had greater atrophy of the ganglion cell interplexiform layers over time. So really, a lot of studies demonstrating an association of obesity and MS risk, including longitudinal analyses. With respect to obesity as a prognostic factor in those who already have MS, the data do suggest there is a likely adverse impact of obesity and related comorbidities on neuroperformance measures. And longitudinally, it does appear to be associated with gray matter volume changes. I think that these data do require some additional replication. It would also be interesting and useful to look at, say, change in body mass index or the acquisition of obesity related comorbidities over time to see if that leads to sort of an inflection point with respect to gray matter volume changes or neuroperformance test changes. And really, prospective studies should also try to investigate the mechanisms by which adiposity or metabolic syndrome components may influence MS outcomes. There may be several mechanisms, and it's important and interesting to drill down on whether these mechanisms are specific to MS, in other words, accelerating MS-specific damage to the central nervous system, or if they cause independent damage to the central nervous system that essentially delivers a second hit in people who already have injury from their MS. Next, we'll turn to looking at the literature surrounding diet and MS risk or prognosis. So there have been a number of recently published studies, and I'll try to review these in as great a detail as we can, given the constraints of the talk. So one study that was published using data from the UK Biobank, which is a population-based study, this was cross-sectional, and they characterized whether people were following healthy lifestyles, which they indicated as being non-obese, a non-smoker, a person who exercises, and a person who follows the American Heart Association uh, diet in terms of quality. And they looked at how many of the components of these four components existed within an individual and ranked from 0 to 4, a categorical variable, and looked at whether that was different among people with multiple sclerosis. And they included 728 individuals versus age and sex matched controls. And they really did see a pretty meaningful association with, in particular, those with 3 or 4 healthy lifestyle components having a much lower odds of being an MS case. What about dietary patterns and MS risk? In the Immune study, diet was classified on a healthy diet scale, and they looked at whether higher degrees of dietary health were associated with risk of MS, and indeed, those who had healthier diets had reduced odds of multiple sclerosis diagnosis. And this was assessed at the time of MS onset or diagnosis, so relatively early in the course, but nonetheless a case control study. With each standard deviation higher, healthy diet score associated with an odds ratio of 0.75 for being an MS case. In the same population, the alternative Mediterranean diet adherence was protective against MS, particularly in those who ate unprocessed red meat. In the nurses' health study, both 1 and 2, there appeared to be no meaningful association of healthy diet scores and MS risk. And healthy diet in this study was assessed with the alternate healthy eating index, the alternate Mediterranean diet index, and the DASH, or dietary approaches to stop hypertension index. So slightly divergent results. What about looking at specific components of dietary intake and MS risk? So there have been a number of analyses of the MS Sunshine study, and this evaluated the association of MS risk initially with fatty fish intake and genetic variants associated with fatty acid metabolism. And this study suggested that those who had reported previously eating at least 1 serving of fish, fatty fish per week, were much less likely to be an MS case. Genetic variants associated with fatty acid metabolism also independently associated with lower odds of multiple sclerosis. And retrospective reporting on childhood consumption in this cohort demonstrated that those who reported greater fruit and yogurt intake, and as preteens or teens, those who consumed a greater number of legumes, were less likely to be an MS case. Similar to what was seen in the MS Sunshine study and the Immune study, those who reported eating at least 2 servings a week of fish were less likely to be a case of MS, and this association was particularly strong for those who reported eating tinned fish, suggesting, again, the role of the fatty components of the fish, the fats in the fish, as relevant potentially to risk. It's really important, and the authors point this out, when you're studying people who already have MS, they are cases, even if it's quite early in the course, they may actually already have changed their diet in response to receiving the diagnosis. We've learned a lot of details recently about the MS prodrome, a period of time leading up to the first obvious MS clinical attack, during which nonetheless people with MS may not be feeling quite as well. They're seeking extra care, they may have increased fatigue, et cetera. And so it's possible that, people with MS, even in the years leading up to their more definitive onset neurologically, already have tried some changes in their diet to see if they could feel better, or just with recall bias or subtle bias that occurs in thinking about one's past dietary intake. It's possible that people misrecall their actual intake over time. So, of course, ideally, what we would like to look at is prospective, population-based analyses that evaluate dietary intake throughout life in a large population of people, some of whom then go on to develop MS over time, and then compare their dietary intake throughout the years to those who are matched otherwise and don't develop MS. What about thinking about the course of multiple sclerosis? Well, many diets have been proposed to influence the course of MS. When I first became interested in this topic, I remember doing a Google search, and there were 13,000 hits for diet and multiple sclerosis. And this was almost 10 years ago. And many of the websites that I looked at claimed to have the perfect diet for people with MS, but they were all different diets. So, very confusing for an individual who's newly diagnosed with MS to figure out what they should be doing. I think we could say there's some emerging evidence for a generally healthy diet being associated with some indicators of less severe multiple sclerosis. I would argue that right now we don't have evidence for a specific diet having the best or the most impact on multiple sclerosis. Those that have been proposed or studied in most detail include the modified Paleolithic diet or Wahls protocol, gluten-free diet, Swank diet, a low-fat plant-based diet, fasting style diets, low sodium diets, and Mediterranean style diets. And we'll talk a little bit about the epi of some of these and then get into some of the clinical trials. So salt was a very popular putative risk factor and prognostic factor several years ago. And so several studies looked at whether in people with already diagnosed MS, salt intake was associated with any evidence of greater disease activity. One study in that was Argentine looked at 70 individuals with relapsing remitting MS, and they used a single spot urine sample, which is not the gold standard for measuring salt, and looked to see whether that was longitudinally associated with relapse rates, and did find that that might be the case. And then cross-sectionally, they did find some associations between higher urine sodium at one time point and radiographic outcomes. In a pediatric relapsing remitting MS and clinically isolated syndrome cohort of nearly 200 individuals, they assessed dietary salt intake by a food frequency questionnaire and did not find an association between the amount of salt consumed and time to first relapse. And then in a large reanalysis of the benefit trial, so nearly 500 individuals who also had spot urines that measured salt only, but a median of 14 of them, so suggesting better coverage of actual salt excretion and thus intake. There did not appear to be a meaningful association between dietary salt and clinical or radiological outcomes over time. Overall dietary health patterns and relapse risk. This was a recently published analysis of data from Australia by Steve Simpson and colleagues. They looked at food frequency questionnaires, which were administered in the Immune study, and they used this to generate a prudent dietary score, so generally looking at the overall health of the diet, and evaluated the relationship of this dietary score to the risk of relapse in those who were newly diagnosed with MS or clinically isolated syndrome, and demonstrating if you dichotomize that score, yes, generally people are eating healthier diets appeared to have a lower risk of relapse over the follow-up period. We have some cross-sectional data from our CHARM study, which is characterizing healthy actions relevant to MS here in Baltimore, where we leveraged the neuroperformance data I told you about earlier, iPad-based analyses of, in this case, walking speed, demonstrated in these graphs, and demonstrated that in those individuals, those who had higher or healthier diets in general, we're more likely to do better with respect to walking speed, whether we mapped the diet to a healthy eating index generally or to the Mediterranean diet score. And the results were generally in the same direction for cognition and hand dexterity. looking at self-reported MS outcomes. Kate Fitzgerald, who's in our group, also looked at the US-based NARCOMS registry, which in this analysis included nearly 7,000 individuals, and they mapped dietary quality to an index and prioritized higher intake of fruit and vegetables and whole grains and lower intakes of red and processed meats and added sugars, and demonstrated those with the highest quintile of diet quality, shown on the x-axis of these graphs, were less likely to self-report disability as determined by the patient-determined disease steps, and also were less likely to be depressed. Again, cross-sectional study, but quite impactful association. Two recent publications from Australia and the Netherlands with nearly 1,500 patients and over 700 patients, respectively, again, demonstrating that healthy diet generally correlates with better metrics of self-reported disability and aspects of quality of life. And then another study published again by Steve Simpson and Yap and colleagues, recently published, mapped diet to a dietary health index, the DHQ, and demonstrated that individuals with the highest degree of dietary health based on this index were also less likely over a short period of follow-up, 2.5 years or so, to have mapped disability progression of their multiple sclerosis. A longitudinal analysis looked at the association of dietary health indices and the development of new lesions on the brain of individuals with multiple sclerosis assessed by MRI scan at baseline and follow-ups. They calculated a heart healthy scores. This was not specific to diet, but included age, smoking, body mass index, dietary intake, exercise, and alcohol. But the diet component of the heart healthy score nonetheless did correlate with greater 5-year change in T2 lesion load. A recent analysis by Alana Katzand and colleagues in New York City looked at 180 patients enrolled in a cohort of individuals seen within their first 5 years of MS onset. They calculated a Mediterranean-style dietary index called the MIND diet score in these individuals and assessed whether that correlated cross-sectionally with MRI measures after adjusting for relevant demographic, socioeconomic, MS therapy, physical activity, BMI, and calorie intake variables, and demonstrated that yes, in fact, higher adherence to a MIND diet was associated with more preserved thalamic volume. So in summary, I think most of the data we have surrounding dietary patterns and components are from cross-sectional studies. They demonstrate that generally healthy diet correlates with potentially a lower risk of MS with some of the caveats as we discussed. And in particular, perhaps there's a protective role of fatty fish intake. These studies also showed that healthy diet correlates generally with better neurologic task performance, and less self-reported disability and depression, and higher thalamic volumes on MRI scan. There may be associations of healthier diet more longitudinally with lower risk of relapse and lower risk of disability. These are very short-term studies, so I think we need to follow these carefully over time, and it would be interesting, just like for obesity, to evaluate whether change in diet was associated with change in risk of inflammatory or neurodegeneration related outcomes for people with multiple sclerosis. And I'll just point out, it's pretty hard to study a lot of these dietary patterns or specific components of diet or micronutrients for their association with MS risk for some of the reasons we've discussed already, such as recall bias and challenges with getting gold standard assessments of dietary intake that are representative and change over time. And so, ideally randomizing or doing some interventional studies might help assess some of these more clearly. To that end, we'll next focus on dietary trials, the challenges of implementing such trials, and the results of the MS dietary intervention studies that have been completed to date. So I became interested in considering dietary intervention studies several years ago. And I realized as I was considering what to study and how to design the study, that these are really hard to do. So unlike a medication trial where, it's easy to think about some aspects of the design, what dosage of a diet do you select for a dietary intervention study? How often does that component of the diet need to be delivered? If you're looking at, say, if people with MS eat more fatty fish, are they, less likely to have bad outcomes? How often do you need to ask them to eat the fatty fish? How long should the dietary study go on? And what kind of intervention is there? There are a lot of suggestions of different nuanced types of healthy diet patterns that we've discussed. Should one intervene on the entire diet as a whole? Should one intervene looking at specific components of diet? It's quite challenging. What patients with MS should be engaged in the trial? Are you looking in early patients and individuals who are at risk for progression, those who are already progressing? Where should the dietary study be done? Classic dietary intervention trials are called controlled feeding studies, where individuals classically are studied for outcomes like hypertension or other things that kind of occur in a short period of time. And they often administer the diets in a controlled research setting where people eat most of their meals in that setting, so that the study personnel can measure exactly what's being consumed and account for and adjust for variations relative to what's prescribed. In people with MS, often our outcomes take a longer period of time to occur, and our patients are younger and tend to be working or otherwise occupied during the day. So asking them to come in over and over again for controlled feeding every day, 5 days a week, is challenging. And if you're not doing that, then how do you ascertain whether somebody is, eating what you ask them to eat? What outcomes should be studied in an MS dietary intervention trial? Of course, we're interested in neurologic outcomes. How are people doing on their neuroperformance tasks? Are they having relapses? Are they having alterations in their disability trajectory? Are they, impacting on their brain MRI volumetrics? Maybe patient-reported outcomes are actually most meaningful. So if people report less fatigue and that sort of thing, or increased ability to function during their day, that might be relevant. Maybe we just want to focus on finding some biological pathways of relevance and then turn back to medications to find out if those if biological interventions can mimic potential benefits of the diet. I mentioned already that it's pretty hard to measure dietary adherence, especially when there's not a controlled feeding trial going on. Ideally, of course, the gold standard is really to do repeated 24-hour recalls that often are administered by study dietitians. However, that is challenging financially and also challenging for participants, really, to take time out of their day, several days per week or month, to go through all of the food they ate over the last 24 hours. Is there something that can be used in the modern era of technology other than self-report? There are a lot of interesting apps and other things coming along that might improve capture of foods that people eat, but they have their own limitations. I do think for supplement type of interventions, say vitamin D trial that we just completed, or things like that, it's often easier because it's simply similar to regular therapeutic intervention trials. And then finally, what should the intervention be? There are many, many different kinds of dietary interventions that have been considered for MS, as well as many related disorders. What should we try first? So let's look at the studies that have been conducted to date. Alana Katsan published in 2019 the results of her pilot trial of a Mediterranean-style dietary intervention. This was really looking at feasibility and impact on MS symptoms, and they randomized 36 people with MS to either a Mediterranean-style diet that was low in salt, and also intervened on the time of day in which people were eating, compared to a non-dietary intervention group. And they followed individuals for 6 months. The intervention included meetings in small groups with dietitians, a lot of education at baseline, and then they followed up at 2 weeks and then monthly. And the control group received educational seminars about multiple sclerosis not focused on nutrition. And then after the study was complete, they were given some details about nutrition. They found in their cohort that it was relatively easy to enroll individuals. Self-reported adherence at 90% at the end of the study, and 100% of people in the intervention arm completed the study. Overall, in terms of clinical impact, those who changed their diet to a Mediterranean-style diet noticed improvement in fatigue. Vijay Yadav published a few years ago the results of their low-fat plant-based dietary trial in people with MS. This was a study randomizing people with multiple sclerosis to a low-fat plant-based diet, 32 individuals versus 29 to a waitlist control, and they were followed for a year. They also found great adherence for their intervention group. They did not find an association between the dietary intervention and relapse, MS-related disability, or MRI outcomes. Their intervention group again reported improved fatigue scores, anthropometrics, and lipid and insulin measures. The Terry Walls recently published on the modified Paleolithic versus Swank diet. This is a pilot trial looking at the modified paleo, which focuses on reduced gluten, casein, and lectins, and also alters other components of the diet. And they compare this to the Swank diet, which is a low saturated fat diet that in the past had been associated in observational studies with better outcomes. And after excluding 8 people during an 12-week run-in of usual diet, 87 individuals with relapsing remitting MS were randomized to one or the other diet and then followed for 24 weeks. Both groups also received a multivitamin, folate, B12, and vitamin D3 that was adjusted to a target level. And their primary outcome was change in fatigue severity score at week 12. You can see on the upper left that there was no meaningful difference between Swank or Walls with respect to change in fatigue severity score at either 12, the primary endpoint, or 24 weeks, although both had improvements compared to baseline. At 24 weeks, there was a slightly greater improvement in modified fatigue impact score, as shown on the upper right-hand column. And then quality of life scores also improved, both mental and physical, the lower left and the lower right graphs with both studies. Some suggestion, as indicated by the comparison bars, of a potential for slightly greater improvement in those on the Walls diet, although notably adherence and follow-up was a little bit less, particularly at 24 weeks for those individuals. Interestingly, they also reported not at 12, but at 24 weeks that individuals on the Walls diet had improvements in their 6-minute walk test. I'd argue looking at the scores and those randomized to the Swank compared to the Walls, that they were pretty different at the time of run-in, or at baseline rather, where individuals in the Swank group had actually had a more than 20-meter improvement between their run-in and their baseline, whereas those on the Walls diet had a reduction in their 6-minute walk test distance between run-in and baseline. So there might have been differences in randomization or whatever happened to individuals during that run-in that really accounted for the apparent discrepancy and changes seen later in the study. We're very interested in fasting style diets and their relationship to outcomes in individuals with multiple sclerosis because mouse versions of multiple sclerosis indicated that fasting might be relevant. So, for example, in MOG, experimental autoimmune encephalomyelitis, which is a mouse model of MS, fasting or calorie restriction was associated with prevention or reduction in severity of MOG EAE, associated with reduced pro-inflammatory cytokines, increased endogenous corticosteroids, more favorable T cell profiles with greater Tregs, and reduced Th1 and Th17 cells. Interestingly, also associated with promotion of remyelination and protection of oligoprogenitor cells and oligodendrocytes from apoptosis. Similar results overall shown in Cooper-zone models, and then shown on the lower right-hand side, these fasting style diets appear to be associated with less axonal injury. And there are data to suggest beyond MS animal models, but other models of neurodegeneration that fasting may be beneficial for neuroprotection. How might that be possible in individuals with MS? Well, targeting autoimmune process and inflammatory processes is, of course, impactful, and this might be influenced by calorie restriction or fasting. And calorie restriction or fasting may also impact on mitochondrial dysfunction and or reactive oxygen species, and thus we thought that these types of diets could influence both inflammatory disease activity in people with MS as well as axonal injury and long-term disability. So, what's been studied with respect to fasting style diets in people with MS? There was a pilot trial of 20 individuals who underwent the modified Atkins diet. And this aimed to evaluate safety and tolerability. It was a single arm, open label study, 6 months. And individuals underwent daily urine ketone testing. Which was self-administered, but they took pictures of their dips of their urine, and they measured adherence by documenting trace ketones or higher for at least 85% of days. And there they said that 95% of individuals that had adhered at month 3 and 75 were still adhering to the diet at month 6. And there were no serious adverse events. The patients had better body mass indices and reduction in total fat mass and reduced serum leptin levels and reported better fatigue and depression scores. We did a trial funded by the National MS Society called ATAC-MS, which was alternating the timing or amount of calories in multiple sclerosis. And this was a controlled feeding study of 36 individuals with MS. They had to be 18 to 50 and have a body mass index of greater than 23 kilograms per meter squared. They had relapsing remitting disease with a duration of less than 15 years. They had to have had a relapse or new lesion in the past 2 years and had to be able to walk without aid. And they were taking either no MS therapy or injectable MS therapy at the time. We designed the study to include a control arm that ate 100% of their daily calorie needs to maintain their current body status, and then 2 types of calorie restriction. One group underwent what's called continuous calorie restriction, where about 22% of their calories were removed every day. And then another group had intermittent calorie restriction, where the same calorie deficit was delivered. It was just delivered over 2 consecutive days, such that they had a marked reduction in their calorie intake to about 25% of their daily calorie needs on 2 days in a row. So overall, the weekly calorie deficits were equal between the 2 groups, but it was just administered over a different time course. And the initial part of the study, again, randomized a controlled feeding trial. So instead of asking patients to come into a feeding center, we actually worked with USDA, Human Nutrition Research Center, and they created the diets individualized and customized for a given patient's calorie needs, and then shipped them directly to the given participant. At each visit, 24-hour dietary recalls were conducted. To assess adherence, and we collected patient-reported outcomes at every time point. Um, Interestingly, we designed the diet to be otherwise similar to not introduce co-intervention to a typical American diet. And so the macronutrient content with respect to fat, carbohydrate, and protein intake was very similar for the provided diet compared to what participants reported eating prior to participating in the study. So again, 36 individuals randomized to each of the three types of interventions. We had fairly good follow-up at the 8-week end of the controlled feeding period. We saw that in general, the individuals assigned to intermittent calorie restriction had a little bit more difficulty with adherence, whereas individuals assigned to the control diet ate a little less than was provided, and those assigned to daily calorie restriction ate even less. And so that's something that we could account for in statistical analyses. Not surprisingly, as shown by the graph on the right, uh, the dietary interventions produce the most amount of weight loss in those assigned to the continuous calorie restriction, combination of reduction in calories by design, as well as even better than expected adherence. Intermittent calorie restriction group lost an intermediate amount of weight, and the control group, because of reduced intake relative to what was provided, also lost a little bit of weight. With respect to patient-reported outcomes, we overall saw that calorie restriction itself was associated with clinically meaningful improvements in depression symptom severity. It was also well tolerated overall. With respect to biological outcomes, we were interested in the impact on the metabolome of this particular intervention. And so, metabolomics refers to a technique to study widespread and unique chemical fingerprints called metabolites in biological media that really tell you a lot about specific cellular processes that are ongoing. They can be targeted, where you're studying specific things in which you're interested, or untargeted. Shown on the right, we had previously demonstrated meaningful differences in people with MS and healthy controls with respect to the overall metabolic profile. And this is thought to reflect an integration of genetics, but also diet and the action of the gut microbiota. In the ATAC-MS, intermittent calorie restriction study, we conducted metabolomic analyses in a single batch. This was done by Metabolon, by LC Mass Spec, and they obtained relative abundances of metabolites. And Kate Fitzgerald in our group conducted a metabolic longitudinal and metabolic network analysis to evaluate biologically relevant networks. And again, this can be adjusted for actual or expected weight loss and adherence and things like that. So we won't go into extreme details about this, but you can see several potentially functionally relevant groups of metabolites that shifted in individuals who did calorie restriction, including phosphatidylcholines and lysolipids, fatty acid metabolites, phospholipids and plasmalogens, and bile acids. Here in these network analyses, the size of the node notably denotes statistical significance over time, with larger nodes being more significant. And so we're hoping to soon publish these data. We've actively linked the metabolic or metabolomic changes with changes in the immunophenotype, so stay tuned. What's the future of these fasting style diets in people with MS? Well, in our trial, after the 8-week controlled feeding portion was done, we asked everybody whether they'd been on the intermittent calorie restriction or not to then switch over to a self-directed intermittent calorie restriction for an additional 40 weeks. This proved to be pretty difficult for most people. And we really realized that doing larger and longer studies of intermittent calorie restriction with a controlled feeding mechanisms would be really prohibitive given costs and adherence issues. We were interested in whether time restricted feeding would have a similar impact. This essentially means one consumes all of one's calories within a specific window of time so that the fasting period extends at least beyond 12 hours. And this is thought to induce some similar effects as the types of fasting that we had studied in the ATAC-MS trial, and aligns better the eating patterns with the circadian clock. And as an example, we conducted a very convenient study of people taking natalizumab and individuals were willing to participate in a calorie restriction or fasting style diet were then randomized to time restricted feeding, so where they ate all their meals within an 8-hour period of time, or control. And we did see interesting changes in the metabolism of several fatty acids and amino acids. So we are eager to sort of move this type of dietary intervention forward for further study. So, overall, I hope I've convinced you that diet is likely quite important for MS because of direct effects, as well as by influencing obesity related comorbidities in the gut microbiome. Each factor does not likely exist in isolation. These lifestyle factors may be quite intertwined, and it may be reasonable while we're looking for specific dietary recommendations to help people and encourage people with MS to pursue sensible diets and exercise modifications. And then design, in terms of future studies, we really do need some better trials of dietary intervention studies, but attention to excellent study design is critical. And I point you to an article that Kate Fitzgerald and Alana Katzand and I put together a year ago or so to think about some of the design elements. And I would argue finally that metabolomics provides the opportunity to observe the biological effects of dietary change beyond some of the more obvious clinical measures and may point us in the direction of therapeutic drug development. Thank you very much. And with that, I will take any questions.